So you can start the presentation.
Good evening to you all.
Yeah, we can hear you. Yeah.
Can you hear? Okay.
Yeah.
Thank you, Vishnu, for your kind introduction. I would like to thank Badicular Medical Association for inviting me this webinar on COVID. I would talk on management pitfalls. I will not go into the details of management. I'll rush through. So as you all know, management of COVID is not a cakewalk. So we struggle since 2019. However, we see some improvement in the clinical management compared to the dark era of the past. COVID-related disease is classified according to the severity of disease. As you all know, this is mainly because of type of care and treatment we provide vary with the degree of hypoxia. In other words, symptoms. So, positive diagnostic test asymptomatic in individuals in a different classifications. Symptomatic mild disease without hypoxia is a different classifications. Next slide, please. And moderate disease, hypoxia is there, but in the absence of features of severe pneumonia. Next, please. So these all classification, you know, it's in the our health ministry guideline, and you can go through. So it's a severe disease, as you know. I'd like to remind you, saturation less than 94, and there is another signs or symptoms. Respiratory rate is more than radiographic infiltrates, PF ratio, SF ratio, and hemodynamic instability. So we classify, and so classify according to the severity and hypoxia, and you should monitor hypoxia because of various reasons, mainly because of to assess the severity. So severity is important. Severity and disease progression is important. With that only we decide the treatment and so on. Next slide. So symptomatic care, as you know, you can symptomatic paracetamol, antihistamine, bronchodilators. You can continue the usual medication. Even ACE inhibitors, ARB can be continued. So if they are taking already, an asthmatic can continue. So these are the symptomatic care. And next slide, please. And oxygen therapy for hypoxic patients. So I will come to that. Next slide. And also venous thromboembolism prophylaxis should be prescribed for all the patients unless they are contraindicated. And antibiotic stewardships. So you carefully select antibiotic. Whether it's first of all, you see whether it's really necessary, and go on whether it's really necessary. Next slide, please. A severe disease. So we are very concerned about severe disease and moderate disease. So how are you going to manage with patient with moderate and severe disease? So they need more attention. We encounter words, very unfamiliar words like viral sepsis and hypoxia and so on. So monitoring of hypoxia, close monitoring of hypoxia is necessary. And if the hypoxia is there, we must go into the oxygen therapy. There are various types of oxygen therapies. So if mild disease, mild hypoxia, you can give nasal mask, nasal mask or facial mask with oxygen, our wall oxygen or oxygen concentrators. So you can't deliver more than 15 liter more than 8 liter oxygen by our wall oxygen. Or then you should go for high flow nasal oxygen. High flow nasal oxygen, in fact, is not non-invasive. It's a flow oxygen. So you give oxygen with humidified air, and if you can't, sometime problem with lung compliance, you go for CPAP and then BiPAP. And so BiPAP and CPAP, you decide whether they need PEEP or and bilevel pressure support, then BiPAP. And also there are some positioning during prone positions, awake prone positions. So it's if you ventilate with paralyzed, then prolonged prone positions, intermittent prones. There are a lot of things. Prone position is better, but there are practical problems. So next slide, please. So how to decide on intubation? Intubation is the last step. So it carries a lot of mortality if you intubate COVID patients. So there are indications for intubations: rapid progression over hours, lack of improvement over 50 liter per minute of high flow oxygen, and FaO2 60%, evolving hypercapnia, hemodynamic instability, and multi-organ failure. So it's keep a low threshold, fine. So please keep low threshold for intubation. Next slide, please. So how to predict the progression of the disease? This is important. So we know all these guidelines and when to give oxygen and all those things. It's all standard on protocols. So how to predict the progression? That is very important. So how to predict the progression? So can you go to the next slide, please? So if you see this graph, so this is important graph, actually. So this is important in each and every patient. So better to have a graph for this each and every patient. So you know where you stand, and it will be easy to navigate through the treatment channels if you know this. So purple line indicates viral RNA, and the red line indicate IgM, IgG. Next slide, please. So if you see the next slide, it shows, so incubation period 2 to 14 days. Then first week, you get gradual viral RNA decline. And second week onward, you get early inflammatory phase, secondary infection phase, and hyperinflammatory phase. So the treatment also, you should start in the correct point, and correct timing is important. If you start antiviral in second week, it's not going to help. If you start steroid during the incubation period, or soon after the incubation period, so it will be harmful with viral load. So next slide, please. It shows this slide shows what are the line of treatments and the timing. So incubation period, and first week, second week, third week, and fourth week. Patient rarely survives beyond third week. And if you see vaccines, monoclonal antibodies, antivirals, and innate immune modulators all work within that first and early part of second week. And second week onward, you can give immune modulators. And second week, you start anticoagulation because patients are prothrombotic. And third week, you expect some bad complication like bacterial sepsis, fungal sepsis. So expect complication and ready for the management. Next slide, please. So there are some comorbidities which can aggravate the progression. So if you find such comorbidity, you must be very careful. You have to admit the patient. You have to very closely monitor for hypoxia and complication like diabetes. Obesity is it's a second big risk factor in COVID complication, COVID disease. Chronic kidney disease, hypertension, ischemic heart disease, asthma and COPD. Elderly people, more than 60 years, also a risk factor, and immunocompromised. So if there are comorbidities, you must be careful. Next slide, please. So, secondary deterioration. So patient will come with COVID pneumonia. So you start treatment. So start treatment is, so according to the protocol. So it's hypoxia, you start dexamethasone. So dexamethasone, you start. So first day, second day, third day, then patient may deteriorate. So what is the cause for the deterioration? So you give dexamethasone. Dexamethasone is a proven treatment in COVID pneumonia. So there are a lot of trials favoring Dexa in COVID pneumonia, but you can use other corticosteroid as well. So if you use dexamethasone 6 mg daily in COVID pneumonia, which is a very low dose, not high dose, low dose dexamethasone we use. So if there is a secondary deterioration, you must think about whether the dexamethasone doesn't work or work. So you can change over the dexamethasone to methylprednisolone, pulse therapy, and see. So you can, sometimes people will answer for high, or you can increase the dexamethasone dose. And also, so you can give the methylprednisolone pulse therapy for 3 days. Then you can continue with the dexamethasone. So if there is a deterioration, but it's a secondary deterioration may be not purely because of treatment failure, maybe due to some other causes as well. So sepsis is an important cause for secondary deterioration. Cardiac causes can be myocarditis or MI. COVID pneumonitis. Earlier you can get acute pneumonia, viral sepsis, and then COVID pneumonitis can cause deterioration. So pulmonary embolism also a cause for secondary deterioration. So what are the investigations? This is important. So if you must do certain investigation if there are no improvement in the clinical outcome after first or second days. So mind you, if you start dexamethasone, there will be some improvement second day. Even if the one dose, patient will get improvement. If there are no improvements, so after second dose, you must think about some other causes and you must investigate thoroughly. So do HRCT, echocardiogram, CT pulmonary angiogram if you suspect pulmonary embolism. And procalcitonin is a very useful investigation to differentiate viral sepsis from bacterial sepsis. So procalcitonin, CRP, and lactate level. You do D-dimer level. D-dimer level in severe diseases goes up to 6 times the normal. There is very high D-dimer level. You must be very careful. You may need to increase the dose of steroids, or you have to add tocilizumab or monoclonal antibody that is recommended for severe disease. After multidisciplinary team or CTP, LDH, and ferritin also you can do. So do those tests and see whether there is any problem. So once you do the investigations, you can, if you analyze, you can always find out the cause for secondary deterioration. Next slide, please. So as I said, this tocilizumab is indicated in severe diseases, but it's a monoclonal antibody. You can't give if there is a liver transaminitis or bacterial sepsis. So please exclude bacterial sepsis before you give tocilizumab. You may need to do procalcitonin level and to exclude bacterial sepsis. And so if there is any comorbidities management, you continue the treatment of comorbidities. Usually it will not cause much problem unless it's associated with respiratory disorders like COPD. Diabetic, you almost always start insulin, soluble insulin. There are other pools of thoughts as well, but insulin is better as far as I'm concerned. So if the patients are immunocompromised, you have to be very careful. It can cause steroid, can cause problem, can cause secondary bacterial sepsis. Sometimes strongyloiditis. If you suspect if you are living in a strongyloiditis, you can give ivermectin. Ivermectin is indicated for secondary worm infestations, but there are trials ongoing to add ivermectin in the current protocol, but still there are no firm evidence to ivermectin. Don't forget the stress ulcers and other complications. So like the AKI, AKI and myocarditis are not very problematic diseases in COVID if you do manage carefully. If patient comes, if severe disease or moderate severe patients, when patient admitted to a ward, initially you hydrate the patients. Usually they are dehydrated. If you don't dehydrate the patient, so they may develop AKI, pre-renal failure, which can complicate the AKI of COVID disease. And even though if you hydrate initially, later you keep the patient slightly in the negative balance because of pneumonia and hypoxia. So most of the people, unless you intubate, they are awake, and to encourage enteral feeding. So don't go for NG feeding. Enteral feeding is better, and as I said, it's you keep low threshold for the intubation. And there are some management modalities. As I said before, nasal high flow oxygen, CPAP and BiPAP. So you go for CPAP if work of breathing is high. The lung is compliance is very poor in COVID pneumonia. So you think very poor compliance, you can go for CPAP. If they are obesity, you prefer CPAP. And if X-ray shows basal atelectasis, you go for CPAP rather than high flow oxygen. And if you need PPAP or PEEP or tachycardia, you prefer CPAP. BiPAP, of course. So if you continue ventilation in BiPAP for longer period, you will end up in barotrauma. So as far as possible, you avoid pressure or PEEP in patient with COVID pneumonia. So before I wind up, there are few emerging therapies. Few trials showed the aspirin, low dose aspirin is beneficial. So it's in the infectious disease journal. And as I said, ivermectin, and there are monoclonal antibodies. So few monoclonal antibodies are approved for early disease. So a few diseases are emerging, but so no sound evidence for these medicines. And supportive therapy, as you know, is important for COVID pneumonia. Thank you very much.